ম্যাডাম আমরা এখন লাইভে আছি। অশোক স্যার আপনি শুরু করতে পারেন।
Yes, thank you. So my respected teachers, my dear colleagues, very good evening and welcome to National Heart Foundation Cardiac course for postgraduate students. Today our topic is discussion on examining chest X-ray. We have got three speaker today, and our expert panel is Professor Manjur Mahmood. He is the professor of cardiology, Bangabandhu Sheikh Mujib Medical University, and speakers are Dr. Dhiman Bonik, Dr. Shamim Ahmed, and Professor Fazila Malik. And Dr. Dhiman Bonik, first speaker is Dr. Dhiman Bonik. He will be talking on basic concept of chest X-ray and radiological findings of shunt anomaly. That is very important topic for examination. And each speaker will get 12 minutes for lecture, and after 3 lectures, we will start our discussion and introduction. And we have got our faculties and other experts with us. So I would like to request Dr. Dhiman Bonik. He's the Associate Professor and Senior Consultant, National Heart Foundation. And his topic is basic concept of chest X-ray and radiological findings in shunt anomaly. Dr. Dhiman Bonik, please start your screen sharing, please.
Respected, can I, is it, am I hearing?
Yeah.
Yes. Huh?
Is it visible?
Yes.
Visible.
Yes. Respected moderator, respected panelists, teachers, colleagues, and friends. Today, my topic is on basic concept and shunt anomaly. Chest X-ray is performed to evaluate heart, lung, and chest wall. Normal chest X-ray is done in upright position, taking a deep breath for a few seconds, that is in the inspiratory phase, to reduce the possibility of blurred image. Routine chest X-ray is done in PA view. It is not also known as frontal view. It is posterior anterior view. Expiratory film is difficult to interpret. In a single exception, that is, if there is a suspicion of pneumothorax, then expiratory film can be taken. In chest X-ray, these are the following important points where careful observation should be given in seeing and chest X-ray. That is the position of the patient. In the position, patient should be in straight position, because if the patient is rotated, then the findings will be distorted. And in the side of the chest X-ray, that is the marking of the right and left marker, the top of the film should be seen properly. Soft tissue shadow should be seen properly, as because in the chest X-ray, in the soft tissue there might be subcutaneous emphysema, which might be important in some of our intervention. Bony configuration should be seen in very eagerly, because in case of coarctation, there might be deep notching. Position of the trachea should be centrally placed, and trachea may be displaced in fibrosis or in case of pulling of the lung to a side. Outline of the diaphragm is very important in our cardiological aspect of seeing the chest X-ray, because the right dome would be slightly elevated and the left dome is would be lowered down. If in a patient with CABG, the left dome of the diaphragm is seen to be elevated, that is an important finding in a patient of CABG. In costophrenic and cardiophrenic angle is also important in our cardiological aspect of, because small effusion, small pneumothorax can be missed in seeing this costophrenic and cardiophrenic angle. Borders of the heart, I will mention it in later. Heart size, or the high size is normal, or there is cardiomegaly. Lung field should be seen with a special consideration. hilar shadow, pulmonary vessels should be seen. In female, the breast shadow should be clear seen, and if there is absence, that may be features of mastectomy, and other soft tissue of the chest wall should be seen properly. This is the normal chest X-ray. If medial length of the both clavicle should be equidistant from the trachea, and there it is defined by the point of the clavicle from the clavicular point, that is equidistance. There, if the fifth rib is in the PA view, then it is the poor, not in the PA view, then it is the poor inspiratory effect. And if it is more than 7 anterior ribs is present, it is the hyperinflated lung. Normal exposure of a chest X-ray is said when the vertebral bodies should be visible in the lower part of the chest radiograph. This is the X-ray of showing the right and left border of the heart. Left border of the heart is formed by upper part, this is the aortic knuckle. This is the pulmonary artery or the pulmonary conus, we say. There is the left atrial appendage, and this is the left ventricle. In the right border is the upper part, it is the superior vena cava forms the upper border, and the lower part it is the right atrium. And the lower part in some books it is said that the inferior vena cava comes into play in the right border of the heart. And this is the cardiothoracic ratio. Cardiothoracic ratio is important to delineate the cardiomegaly. It is the midline. It is the maximum convexity on the right, distance from the maximum convexity of the right, it is the A, and the maximum convexity from the left, it is the B, and total transthoracic diameter is C. If A plus B divided by C is greater than 0.5 in adults or in children, it is said to be cardiomegaly. In supine PA chest X-ray, in anterior posterior view, if the ratio is more than 0.57, it is said to be cardiomegaly. And in case of newborn, its ratio is more than 0.6 to said to be cardiomegaly in case of newborn. Heart may appear normal, small in chest radiograph in case of mild to moderate air, where the in presence of air, though heart is enlarged, the apex is shifted, displaced inferiorly, so it appears to be small in size. In patients with COPD, there is large anterior posterior diameter. In elderly patient with severe dorsal kyphosis, the heart may appear small. In case of Addison's disease and anorexia nervosa, heart may appear small due to absence of brown fat. These are the diagrammatic picture of chest radiograph in a frontal view, that is a PA view, and in lateral view. In PA view, this is the more anterior part is formed by right ventricle, lateral I have mentioned LV, and it is this is the in case of PA view. In case of lateral view, the area close to the sternum is the RV, and the area close to the vertebral column is the LV, and these are the pulmonary vessels in the lateral view. The features of right ventricular enlargement, LV, when the right ventricle is enlarged, LV is displaced posteriorly and to the left, pushing the left border laterally, and the cardiac apex is shifted superiorly. So there the left cardiophrenic angle is acute. It is acute. So right ventricular enlargement produces cardiophrenic angle, acute cardiophrenic angle, and RA is also pushed laterally due to right atrial enlargement. In case of left atrial enlargement, left heart is displaced more laterally, and the cardiac apex is shifted downwards and outwards, giving rise an obtuse angle with the obtuse cardiophrenic angle, and the heart is enlarged in transverse diameter. It is the left features of left atrial enlargement. In right atrial enlargement, the right border of the heart become more convex and shifted to the right, and if the distance from the midline is more than 5 centimeter, as the highest convexity of the right border is more than 5 millimeter in adult and more than 4 millimeter in children, it is demarcated as right atrial enlargement. The left criteria for left atrial enlargement will be discussed by Professor Fazila Malik Madam. And the next important thing in chest radiograph is plethoric lung fill in shunt anomaly. In shunt anomaly, it is seen that there are increased pulmonary flow. That in in the pulmonary artery, and there is upper and lower lobe vessels are prominent. If the right posterior descending artery is greater than 17 millimeter in size, or the ratio of the right posterior descending artery and the trachea ratio is greater than 1, then it is said to be plethoric lung field. In normally, the pulmonary vessels, pulmonary flow is more in the lower part and then in the upper part. It is 5:1 ratio. And as the pulmonary hypertension develops, the ratio comes to 3:1 or 4:1, and there is more upper lobe vessels are more dilated then. The pulmonary oligemia is said to be when there is decreased proximal or to origin or male of the main pulmonary artery. This is due to small pulmonary artery or empty pulmonary bay as seen in mitral stenosis, or the pulmonary vessels are small, the lung field are hypertranslucent in case of oligemic lung field. In case of a shunt anomaly, there is left to right shunt, and gradually when pulmonary artery pressure rises, it gives rise to bilateral shunt, bidirectional shunt, and later on right to left shunt, where there is obliterated changes in the smaller and pulmonary artery and arterioles. The main and large central arteries tapered suddenly and rapidly become small and also absent. In the chest, this is also known, this is present in Eisenmenger syndrome, where there is reversal of shunt. If we divided the chest radiograph, the lung field, into 3 parts, that is medial 1/3, mid 1/3, and the lateral 1/3. In case of Eisenmenger syndrome, there is dilated vessels in the medial part, and there is narrowing of the vessels in the mid part, and suddenly there is absent of vessels in the lateral 1/3. It is known as pruning of the pulmonary vessels. It is an important feature of Eisenmenger syndrome or reversal of shunt. This is a chest radiograph which shows that the heart size is normal. There is RB apex, pulmonary vessel is dilated. There is no feature of left atrial enlargement, that is left atrial enlargement is small, inconspicuous, and there is no right double heart border. So this might be an X-ray of ASD with pulmonary hypertension, as because there the important differentials in this RB apex and dilated pulmonary artery will be mitral valvular disease or predominantly mitral stenosis, but it is not mitral stenosis as there is no straightening of the left border and there is no double contour of the right border. This is also a chest radiograph where there is RB apex, acute angle, and the pulmonary conus is full, and there is straightening of the left heart border, but there is no double contour of the right border, and pulmonary knuckle is small. In this X-ray finding, differential should be said. It might be ASD with pulmonary hypertension or multiple valvular heart disease, where there may be aortic valve involvement and mitral valve is also involvement, giving rise to a mild to moderate MS or MR, giving rise to straightening of the right heart border, left heart border. This is another chest X-ray where there is cardiomegaly with LB type apex, and there is pulmonary artery dilated with plethoric lung field. Aortic knuckle is small, and these with these chest findings, these are the differentials of a VSD. It might be shunt anomaly, probably VSD, as because in VSD aortic knuckle will be small, pulmonary vessels will be dilated. And important differential is again a multiple valvular heart disease. In patent ductal atheresias, the chest X-ray depends upon the size of the duct. In small duct, the chest X-ray may be normal, except with a slightly prominent aortic knuckle, almost normal or a prominent aortic knuckle with the chest radiograph normal. This might be a case of small duct PDA, pulmonary patent ductus. In moderate size duct, there may be mild cardiomegaly is present in this chest radiograph. There is LV type apex, aortic knuckle is prominent, and there is increased vascular marking. There is features of pulmonary hypertension, pulmonary vessels are slightly dilated. This is the moderate sized duct, patent ductus arteriosus. In large patent ductus arteriosus, there will be dilated main and branch of the pulmonary artery, and which give rise to middle part of the heart size is grossly enlarged, and there is LV type apex, the prominence of the aortic knuckle, and this is a extra finding of an shunt anomaly, probably PDA, large PDA. In case of this is a chest radiograph where it shows that there is a dilated aortic vessels, inconspicuous left atrium, and it is a RV apex. The pulmonary vessels are dilated, and there is pruning of the chest radiographs, which it is an Eisenmenger syndrome, probably with an ASD. In Eisenmenger syndrome, chest radiography shows dilated central pulmonary arteries with rapid tapering of the peripheral vasculature. These are the important radiographic hallmark of Eisenmenger syndrome. Eisenmenger syndrome due to VSD and PDA are usually normal in size or slightly dilated, but Eisenmenger syndrome with ASD is typically with a large cardiothoracic ratio, because right atrial and left ventricular dilatation is present, along with an inconspicuous aorta reflecting low lifelong cardiac output. This is the three picture side by side giving this is a chest radiograph, shows RV apex, dilated pulmonary vessel, aortic knuckle is small, and there is pruning of the lung. This might be a case of this is the case of ASD with Eisenmenger syndrome. In this picture, in the middle picture, there is LV apex, pulmonary vessel, pulmonary conus is full, and there is aortic knuckle is inconspicuous. It is a feature of VSD with Eisenmenger syndrome, that is Eisenmenger complex. And this is the picture of a dilated pulmonary vessels, aortic knuckle is prominent, and there is LV apex, and there is pruning effect present. This is the picture of Eisenmenger syndrome with PDA. So with this, I end my lecture. Thank you all for patience hearing.
Thank you, Dr. Dhiman Bonik. Excellent speech. Now, I would like to request our panel of experts, Dr. Manjur Mahmood, for his comment, please.
Thank you for inviting me to participate in this session. We have seen interesting exercise from Dr. Dhiman Bonik. So he has emphasized that on the normal chest X-ray and also different varieties in shunt anomalies. The main thing is actually to see whether there is cardiomegaly or not, and what is the left heart border and the right heart border, and ultimately what is the vascularity of the lung, whether it's plethoric or oligemic. So he has nicely said all these things and compared all the X-rays at the same time. So for the students, it is important to notice that whether there is a cardiomegaly and whether there is any right ventricular type of apex or left ventricular type of apex. Then see the left heart border, whether what is the situation of the pulmonary artery, whether it's prominent or not, or there is a concavity of the pulmonary bay, the aortic knuckle, and ultimately if there is any left atrial enlargement, and finally left ventricular enlargement. And also we can see that on the right heart border in the normal chest PA view, if the right border is prominent, it indicates the right atrial enlargement. And he has mentioned that if it is more than 5, then it is assumed that the right atrium is enlarged. And finally, it is important to see the vascularity, whether there is oligemic or plethoric lung field. So by these observations, we can try to distinguish between different types of shunt anomalies. Thank you, Dr. Dhiman.
Thank you, sir.
Thank you, Dr. Manjur Mahmud. Now I would like to request Professor Rahiduzzaman sir for comment and any question or tips for the students.
Thank you, Dr. Ashok. Actually, I think Dr. Dhiman has very nicely covered each and every aspect of chest radiograph in shunt anomaly. I think nothing much to add. Only that the students should go through the lecture again and again to understand all the thing he has mentioned in his lecture, because it's very difficult sometimes to differentiate between the shunt anomalies, because all looks so closely to similar. But what is important, I want to know from Manjur Mahmud, that when a student is given a X-ray with a plethoric lung field and cardiomegaly, how should the student approach to this, and how should he or she answer to the examiner? I think if you can clarify to the students, they will benefit from you.
Okay. In the actual exam, when there are actually at least two X-rays are given in the OSPI section. Previously, there was X-rays in the Viva board. This is no more now. So the X-rays are only given in OSPI exam. So when there is a chest X-ray showing some anomalies, and it is difficult to distinguish between shunt anomaly and valvular heart disease. So we need to see the question. If the question says that what are the radiological findings? If there are 3 marks, so we need to write 3 findings. There should be at least 3 findings to mention. So that gives some marks to the candidate. And then next question comes that what is the radiological diagnosis? So a candidate can write the right diagnosis, or he can write differential diagnosis. If the answer shows, if there is a predetermined answer that shows 1 or more diagnosis, then the candidate will get some marks for that diagnosis aspect. And finally, there may be a third part of the question, which might ask what further investigation you want to do, or how do you confirm the diagnosis. So by answering that, he will get some more marks for that question. So the question has split it into 3 parts, usually 2 or 3 parts, and the candidate should try to get as much information from the X-ray that is given in the exam. And I think by trying this, he will at least get some of the marks in that question when the X-ray is not very straightforward.
Thank you, Dr.
Thank you. Now I'd like to request Professor Amal Chaudhary for his can you hear me?
Thank you, Dr. Ashok. Thank you for nice presentation from Dhimanda. Very basic and very right. I think student topics is also very important clinically, because all of you know clinical X-ray is a part of actually bedside clinical examination. Particularly congenital and valvular heart disease, it's carry a tremendous question in Viva, in oral examination, starting up oral examination, in even then there is definite compartment of X-ray. So every student should know how to approach to the X-ray, in what dimension, in which way. We can say that what are the bony structure, periphery to center, like this. I think in postgraduate that should be the very, very target things like this. What are the positive finding? Even when in my strategy to cope up the better longer time to talk with the student, we ask, this is the X-ray. You say what I see, what I will show this X-ray. What are the for what reason I will show this X-ray? What are the 1 point, what are the 2 points, what are the 3 points in this X-ray is demarcating and to reach the diagnosis. So I think every student, when they will see the X-ray, they will know the basic thing from MBBS. It does not, it can be recapitulated if any dogmatic examiner asks, say the basic how to explain the X-ray, so that he can also able to answer this question, and also the very correlative question, interactive question with the patient, with the examiner, and with the disease. So that what is the 3 things of this X-ray which lead to diagnosis of a particular disease? What are the possibility? What are the first 3 things you show after seeing the X-ray? You can capitulate the 3 diseases after seeing this X-ray like this. Thank you. I think it is a very good session, and recapitulation as well as learning of new things. Thank you, Ashok. Thank you, foundation. Thank you, madam.
Thank you all. Dimanda, you have got on query regarding enlargement of the cardiac shadow or cardiomegaly. What are the site of measurement of heart shadow and site of measurement of the thoracic diameter? In on picture you have seen the maximum diameter. Other way you have seen the lowest part, means below, even below the level of diaphragm. So what is
the A and B, the midline, from the midline, maximum convexity on the right heart border, it is on the right side, and maximum convexity on the left heart border, it is on the heart, and the maximum transverse diameter of the thorax, it is the maximum. It might be on the over the diaphragm or in the lower part of the diaphragm.
But in examination it is difficult. In radiology room it is you can use the scale, but if heart is not enlarged in such a way that right atrium is enlarged at a level where the apex is much below level. So at this condition, so difficult to measure the right side of the heart, left side of the heart. So what is the suggestion for the student regarding the comment, how they would easily comment on cardiomegaly? Any easy way to comment on cardiomegaly? And other thing, sometimes may be confused. If the patient X-ray is taken in the AP view, especially in bedridden patient, then false cardiomegaly may be shown because of position of the X-ray film is on the back side of the patient. So cardiac shadow is enlarged because X-ray is focused from the anterior to the body. So that will be focused in enlarged way, number 1. Number 2, in expiration, diaphragm is elevated and heart become more horizontal. So at that situation, sometimes it seems to be cardiomegaly. So these 3 conditions. So what is your opinion for the student? Because they don't have any scale, they don't have any device to measure the cardiac shadow like this, what you've shown in your picture.
In anterior posterior view, in supine position, the ratio is more. The ratio is not more than 0.5. It is more than 0.57. I have shown in my lecture. It might be a visual impression. It might be a visual impression. If the measurement cannot be done, it might be a visual
like eyeball estimation in echocardiogram. Eyeball estimation.
এবং Dimanda, এবং এখন I think it is only the convexity of the upper part and lower part of the diameter of the thorax in this particular in this situation to determine the cardiomegaly. What is it about Ashok?
No, this is the maximum diameter of the
thorax. It is the maximum diameter of the thorax.
Yes.
It is the maximum diameter.
The accurate measurement that Dimanda have shown, the right border of the heart up to the midline, and left border of the heart, outermost part of the left border of the heart up to the midline.
Eyeball estimation. One thing is that Bidhiman can answer it, how the students can differentiate between PA view and AP view. There are some thing in the X-ray which patient can say that the examiner can say that this X-ray is PA view, this X-ray is AP view. Is there anything in the X-ray which can be a signal to the patient?
Yes, yes, sir. In case of good exposure of a PAVU, the vertebral bodies will be slightly seen in the lower part of the heart. In case of APVU, the vertebral bodies will be more prominent. And if there is more prominent of the vertebral, there should be a suspicion of APVU X-ray. And in medicine practice, if we want to see anything in the thoracic vertebral bodies, we commonly do the APVU in our medicine practice in our training.
And also the ribs, the interior
Also
ribs are more prominent in the
Yes,
APVU than.
And also shoulder blades, sir, shoulder blade.
একটা ইন্টারেস্টিং কোশ্চেন সবার জন্য, অল দ্য প্যানেলিস্ট হিয়ার, এটা একটু ফানি কোশ্চেন। সেটা হচ্ছে যে nowadays it should be answered by radiologists but not us, but তবু আমি কোশ্চেনটা করছি। Lot of X-rays are coming with the comment of cardiomegaly, and when you do echocardiography, the dimensions are all within normal limit, all within normal limits. But X-ray is going, so what is the trick here? All the bolo.
Sir, the trick is this, sir. It is taken in the expiratory phase, sir. In the expiratory phase, the patient, in doing an X-ray, it is asked to hold the breath in inspiration. But the patient or the person who is doing the X-ray, they does not take the breath in inspiration. They are either in expiratory phase or they do the normal in normal X-ray. As because
that become horizontal.
That become horizontal. And in a chest radiograph, in a normal view, anterior portion of the fifth rib should be within the chest radiograph. It is a normal inspiratory peak.
And patient should be asked to take deep breath during
inspiration. And in case of pneumothorax, I have mentioned, in case of pneumothorax, it is written in the books that in case of, if you suspect a patient, it is also important in our part, because pneumothorax is the complication of our different intervention. So if you suspect a patient with pneumothorax, you should take an expiratory phase X-ray. So pneumothorax will be more.
The other thing sometimes may be asked, what is the advantage of over-penetrating view? What are the condition where the over-penetrating chest X-ray is taken? Just few example, sometimes may be asked in
one of our daily practice pacemaker to see the lead.
Yes.
Deep penetration.
Actually, the thing, easy way to remember, calcium over penetration is better seen. So if someone want to see the calcification, like any valvular heart disease with calcification of the aortic knuckle, deep penetration will give the better view as the leads and other foreign bodies like this. Thank you. So may I move to the next speaker? So our next speaker, Professor Fazila Malik ma'am. She is the Chief Consultant and Academic Director, National Heart Foundation, and she will be talking on a very important disease that is sometimes bread and butter for us, and sometimes if missed anyway, that patient should not be passed anyway. So that is the mitral stenosis, mitral valvular disease. Till now, though it is very rare in European and developed country, but in our subcontinent, this is a very common disease, especially in tertiary hospitals. And she'll be, her speech will be on radiological findings of mitral stenosis. Very important, each and every part of the findings and how that findings anatomically happens, that should be described, and that should be remembered by all the students to pass in the examination. So, madam, would you please share? Yeah.
I've already started sharing. Can you see, please?
Yes, we can see and we can hear you all.
Yes. So, a moderator, friends and colleagues and my students, it's indeed a great honor and pleasure for me to be here today. And today I'll be talking about mitral stenosis. So in mitral stenosis, we all understand that there is a problem with the mitral valve. It is stenosed, and therefore what is happening? Blood is not flowing adequately from the left atrium to the left ventricle. And so there is a buildup of blood in the left atrium, and this eventually leads to increase in pressure in the left atrium, increase in volume of the left atrium. And so the left atrium gets increased in size. And gradually over time, there is back pressure, which is transmitted to the pulmonary veins, then to the pulmonary capillaries. And so we have pulmonary venous hypertension. Eventually, the back pressure goes to the pulmonary arteries, and we have right ventricular, right atrial and right ventricular enlargement. So that is in a nutshell the pathophysiology. So first of all, the most important thing that's happening is that due to the valve stenosis, blood is not flowing from the left atrium to the left ventricle. So the left atrium is really increasing in size. So how do we understand radiologically that the left atrium is increased in size? Well, when it grows everywhere, towards the right, the left, upwards and all. So when the left atrium grows towards the right border, which already Dhiman has said is formed by the right atrium, the enlarged left atrial border itself forms a separate silhouette. And this can be appreciated as a double density of the right side. So when the left atrium is enlarged, we get the double density sign, or it is also called a double bubble sign, and it indicates that the left atrium is enlarged, and there are two borders on the right side of the heart. One border is formed, the outer border is formed by the right atrium, and the inner extra border is formed by the enlarged left atrium. Sometimes the left atrium may grow so much in size that it overlaps the right atrial border. And when that happens, we call that a we call it atrial escape. So in this X-ray, you can appreciate the double density or the double density sign. And here we've just marked it so that it is more clearer. So when we have this idea that there could be a double density sign, we will look for it. So we should always look for the extra left atrial margin. Now, when will we think that yes, the left atrium is enlarged? When we have other clues as well. And one very important clue is that there is a straightening of the left border of the heart. So in the right side, we're getting the double density sign, but in the left side, we're getting a straightening of the left border of the heart. And why does the straightening of the left border of the heart happen? Because as Dhiman has already mentioned, there are certain structures which form the left border of the heart. And one of this is the left atrial appendage. So when the left atrium grows inside, it makes sense that the left atrial appendage also grows. And so when it grows, it fills up the hollow or the convexity, the concavity, and it becomes straightened. And the left ventricle is already small in size because it's not getting enough cardiac output. So this all leads to a straightening of the left border of the heart. So in mitral stenosis, classically, we recognize mitral stenosis by looking at the left border of the heart, which becomes straight, and at the right border of the heart, where we get double density. Another thing we understand is that all these signs are being created because the left atrium is growing in size. And one indirect or direct way of understanding this is taking an oblique, measuring the oblique length of the left atrium from its right border to the left main bronchus. And if this is larger than 7 centimeters in size, then it indicates that the left atrium is dilated. So when the left atrium is growing, it grows not only towards the right and the left, it also grows upwards. And when it grows upwards, what structure does it impinge on? It impinges on the main bronchus. And what it does is it causes posterior displacement of the left main bronchus. So the left main bronchus moves posteriorly. And what this creates, it creates, you can, in the lateral X-ray, you can clearly identify the two bronchus separately because the left main bronchus has moved posteriorly. And this posterior displacement of the left main bronchus, together with the normally positioned right main bronchus, looks like a man walking. So this could be an inverted V sign. This is called an inverted V sign, or a mustache sign, or a walking man sign. So in the lateral X-ray, we can get the walking man sign, and this walking man sign occurs because there is a posterior displacement of the left mainstem bronchus. And this is an X-ray showing the walking man sign. So you need a bit of imagination, but in a lateral X-ray, if you see that the bronchus are pretty prominent, and you can see both the right as well as the left main bronchus, and they're separated and look like an inverted V. In examination, you could say that this is due to the enlargement of the left atrium, which has led to displacement of the left main bronchus, and this is the walking man sign. So both the bronchus, not only the left main bronchus moves posteriorly, they both get separated, and there is an upliftment of the left main stem bronchus upwards. So what happens to the carina? The carina spreads out, and there is a splaying of the carina. And when the carinal angle becomes more than 90 degrees, because normally it should be less than 90 degrees, when it is more than 90 degrees, we understand that there has been a splaying of the carina, and this carinal shift has happened because of the enlarged left atrium, which is pushing it and displaying the normal position of the bronchus. Another thing that we need to understand is that we need to understand the left border of the heart. We said that initially there is straightening of the left border of the heart, and this is one of the earliest clues that we have that there could be a possibility of mitral stenosis. Now, one thing that we need to remember is that in radiology, they call the bumps, if these of the left side of the heart, as moguls. And they call them as moguls only when these become more prominent. So the first mogul is the aortic knuckle. So when the aortic knuckle becomes very prominent, it is known as the first mogul. Normally, it will not be called a mogul. Only when it becomes large and prominent, it is a first mogul. And there are certain situations where you will get the first mogul. The second mogul is created by the pulmonary artery. The third mogul is the dilated left atrial appendage. So the left atrial appendage initially formed the straight line when it enlarged. Subsequently, it might enlarge to such an extent that it bulges out from the left border, and it creates an extra bump there. And then it is called a third mogul. The fourth mogul is the left ventricular wall, and the fifth mogul is the prominent pericardial pad of fat. So moguls are only designated as moguls when they are abnormally dilated in the left border. So we have a prominent third mogul in some patients of mitral stenosis. Like in this patient with mitral stenosis who has also pulmonary hypertension, you have cardiomegaly here, the double right border, splayed carina, the prominent pulmonary outflow shields, and the left atrial appendage, which is prominent, and this is the third mogul sign. So when the left atrium becomes very prominent and bulges out, we call it the third mogul sign. And we need to remember also that cardiomegaly can also be seen in mitral stenosis. On the other hand, even with very severe mitral stenosis, there might not be gross cardiomegaly, but cardiomegaly only happens when there is pulmonary arterial hypertension leading to enlargement of the right atrium as well as enlargement of the right ventricle. So here there was pulmonary hypertension, and there is a third mogul sign. So once the patient develops increased pulmonary venous pressure, so there is a chance that the patient might end up with pulmonary edema in case of mitral stenosis. So in mitral stenosis, we get certain findings due to the enlargement of the left atrium. We get certain findings due to the enlargement of the right ventricle and the right atrium. And we also get certain features in the lung field. So we're getting some findings in the heart, and we're getting certain findings in the lungs which are happening there because of pulmonary edema. So as we all know, mitral stenosis is one of the important causes of pulmonary edema. So what happens in mitral stenosis? In mitral stenosis, left atrial pressure increases, there is increased pulmonary venous pressure, and then there is increased pulmonary capillary wedge pressure. And these pressures are very important because a certain pressure will give rise to certain findings in the lungs. So in stage 1 of pulmonary edema, what happens is that there is redistribution of the blood in the lung fields. And this occurs typically when there is acute heart failure, when the pulmonary capillary wedge pressure is between 12 to 17. And in case of chronic, it will be higher than that, like 15 to 25. What do we see? We see cephalization, we see enlarged hilar blood vessels, and we see an increased arterial to bronchi ratio. In stage 2, with increase in the pulmonary capillary wedge pressure, which has become now 17 to 20 millimeters of mercury, there will be interstitial edema. And interstitial edema is evidenced by Curly's lines, by peribronchial cuffing, by the hilar shadows becoming more larger and more indistinct, and forming a perihilar haze. And in stage 3, the fluid goes into the alveolar cavity now, and so there will be airspace opacities or frank pulmonary edema, or the bat swing appearance. And this occurs acutely when the pulmonary capillary wedge pressure goes more than 25 millimeters. So these are findings which are happening due to increased pulmonary capillary wedge pressure. And so first of all, as we said, there is redistribution, and this redistribution is evidenced by cephalization, so or upper lobe diversion, and this is also known as stag antler sign, and the hilar shadows also become enlarged. So here we can see the straightening of the left border, which is an evidence of mitral stenosis. So this, and then when we look at the lung fields, we notice that the upper lobe vessels are more prominent. The hilar is not that clean cut. It looks enlarged. So here we have pulmonary venous hypertension and stage 1 of heart failure. So acute pulmonary edema. And as I was saying, the upper lobe diversion or cephalization has another name also. It is called a stag antler sign. So why is it called a stag antler sign? Because the blood vessels, they branch out, right? And when they branch out, they go towards the upper lobe, they look like a stag's antler. So this is also known as a stag antler sign. Then we come to stage 2. And in stage 2, what happens is that the vascular pedicle, Dhiman already showed you that the vascular pedicle is measured on the right side. You have the superior vena cava. On the left side, you have the aortic arch. So the space between these two, it becomes widened. There is a small dot-like structure in this vascular pedicle, which is the azygous vein, usually very inconspicuous, but this becomes very distended. You start getting the septal lines. There is peribronchial wall cuffing. So there, the bronchi become prominent, and there is opacity around this, which is also known as a donut sign. The fissures become thickened. The heart shadow may look enlarged. And as Dhiman was saying, there might be a pleural effusion as evidenced by blunting of the costophrenic angles. So let's look at these findings that we might find in the second stage of pulmonary edema. So first of all, the Curly's lines. Now, Curly's lines are very interesting lines, and they obviously indicate interstitial edema. And there are quite a variety of Curly's lines. So first is the Curly's B lines, the most common lines. They can occur in any part of the lung, but however, they are very common in the costophrenic angles of the lung, and they are at 90 degrees to the pleura. And these lines are usually 1 to 2 millimeter in thickness, and they are 1 to 2 centimeters in length. And as you can see, they are mainly located in the near the costophrenic angle. So these are Curly's lines, and they indicate interstitial edema. Then the Curly's A lines. Now, Curly's A lines, they branch out from the hilar and go upwards. And these Curly's A lines are usually longer than Curly's B lines. Curly's A lines are only 1 to 2 centimeters in length. Curly's B lines and Curly's A lines may be even 4 to 6 centimeters in length. And how do you differentiate these from the blood vessels? We already talked about cephalization of the blood vessels. Now, one important thing is these lines will disappear after 4 or 6 millimeters. Another thing, these will never branch, whereas the blood vessels, we said, have the stag antler signs. So the blood vessels, as they go up, they will also branch. So this is the differentiate between a Curly's A line and the upper lobe diversion of the blood vessels. And what are the Curly C lines? The Curly C lines are more reticular in appearance, very fine, and they are usually situated between the Curly's B lines and the Curly's A lines. And these are very fine lines. All these lines indicate interstitial edema. And as I was saying, so when you have interstitial edema, so what do we have? We have cephalization or upper lobe diversion. We have increased lung markings and the perihilar region becomes hazy. We have Curly's B lines in this X-ray. And we have a very small pleural effusion. It has been marked as 4, but so there's just a blunting of the costophrenic angle, and this gives us a clue that there is pulmonary edema. So when we have an X-ray and we see straightening of the left border or the double shadow or the splaying of the carina, immediately look at the lungs and see whether there is any evidence of pulmonary edema, because we need to tell these to the examiners if we want to get good grades and pass. So these are the stage 2. Stage 3 is frank alveolar edema. The fluid is already in the lung alveoli. And how does this look? It looks like a bat's wing appearance. So like the wings of a bat, there is perihilar opacities, and this indicates that there is fluid in the alveoli, and the hyla, as you can see, are very enlarged, very hazy, and you can't really make out the vascular markings of the hilum. This is also another extra of the bat swing appearance, acute pulmonary edema, and there is cardiomegaly, there is bat swing appearance. And this is alveolar hemorrhage. So in alveolar hemorrhage also, some patients with mitral stenosis may come with hemoptysis and cross frank hemoptysis, and their X-ray might give evidence of alveolar hemorrhage, that is alveolar opacities. But one interesting finding about alveolar hemorrhage is that usually it has a window frame effect. So what is a window frame effect? There is diffuse pulmonary consolidation. However, there tends to be, in many instances, a sparing of the periphery of the lungs. So this is an interesting clue that gives us idea. And so one important thing is about X-rays is that we really need to correlate these with our patient, right? And in our day-to-day clinical practice, correlating an X-ray with our patient's history and other findings is very easy. In a way, during examination, it's a bit unfair because we're just being given an X-ray and we're expected to know what the diagnosis is. But if we see something like this, this could be a clue. Now, what happens if a patient goes on having alveolar hemorrhage? So what happens is that the iron is taken up the macrophages, and these macrophages are present in the alveoli, and these macrophage-laden iron, eventually we end up with hemosiderosis. So in hemosiderosis, it's a miliary mottling which appears in the lung fields. So if we get an X-ray during our exam, and if it's a third part MD exam, and you first of all notice the miliary mottling, look immediately to the borders of the heart. Is the border straightened? Is there a double density? Is there splaying of the carina? Because this could indicate that this miliary mottling is due to mitral stenosis and is an indication of secondary hemosiderosis. And we need to remember that up till pulmonary edema, the signs are usually reversible because if you treat the patient, the signs will disappear. But once hemosodrosis develops, this is sort of a permanent thing that happens. And with time, you can even end up with calcified nodules in case of mitral stenosis. Here also, you can appreciate the cardiac findings of mitral stenosis along with calcium in the lung fields. This is a very interesting X-ray that we just picked up 2 days ago during our rounds. And as you can see that this gentleman, actually he was on IV furosemide. He had come with pulmonary edema. He had had his surgery done 6 years ago. And you can see the prosthetic mitral valve. I've already marked it just so that you can see it more clearly. And you can see the sternotomy wires. And there's some amount of perihilar mottling and some Curly's B lines, maybe that's my imagination. But this patient had pulmonary edema, and this patient had undergone surgery 6 years ago. So this is also, if someone had this X-ray, they would definitely give it for the examination purpose. I've got some typical sample X-rays for you also. So this type of X-ray would definitely be there in the table, and you might be lucky or unlucky to get an X-ray like this, typical mitral stenosis with pulmonary edema here. Here also bat swing bilateral appearance, straightening of the left border. And so in a brief nutshell, when we get an X-ray of mitral stenosis, we need to look at the left border, the right border. We need to look at the double density, the splaying of the carina, and we need to look at the lungs to see whether there is any Curly's lines, whether the hilar shadow is prominent or not, whether there's upper lobe diversion, or whether there's any frank pulmonary edema, which is pretty easy to detect with the typical bat swing appearance. So that's my take on mitral stenosis, and best of luck with your exams. So thank you from all the cath lab team of National Heart Foundation. Thanks a lot.
Thank you, ma'am. This is nice deliberation, especially very complex thing, very easy way description. Any comment from panel of expert or our faculties? This is very important for examination. So, Professor Manjur Mahmood, any comment?
Yeah. Madam is my teacher, direct teacher. Back in 1993, when I was a diploma student, she was a registrar in ICVD. So it's nice that we have learned a lot from the lecture in detail, because there are so many signs in she has shown in the X-ray a detail of every stages of mitral stenosis up to the final stages of hemosiderosis and gasification. So she has elaborately told us all the stages of mitral stenosis from the beginning. The one important thing is that in the X-ray at the exam, the common problem is with the shunt anomaly, with the mitral stenosis. So Madam has given very important features of in X-ray in favor of mitral stenosis, such as the double right border, if that is seen in the X-ray, that is a very important clue. And straightening of the left border of the heart is fairly easy to see. And important thing is the ASD tends to increase the right atrium dilatation, and mitosis the left atrial dilatation. So we need to see the features of left atrial enlargement in the X-ray. So that can be seen in mitral stenosis. And then if we see the venous diversion in the mitral stenosis, upper lobe venous diversion, and in ASD, all the vessels are prominent from upper to lower. So that is another important clue differentiating with ASD and mitral stenosis. And our teacher also said about the advanced signs such as the inverted V sign that is the Carina sign. And then she has depicted the 5 moguls in the X-ray, which is very new to us and very interesting to notice that when you see the left atrial enlargement, we already said that it's the 3rd mogul sign. So a very important sign. And then the cephalization, that is the upper lobe venous diversion, important to see in the X-ray, which is seen in mitral stenosis. And lastly, the Carley's lines, which are again A, B, or C. Sometimes they're very difficult to differentiate. And she has also told how to differentiate between the venous and the arterial enlargement in the X-rays. So it's in detail that she has told about mitral stenosis, and we can't add anything more actually. So I think
all the aspect of mitral stenosis is covered. So thank you, ma'am. For the student, actually, everything you have to know. Mogul sign, that is a very old term. Then inverted V sign or Workman sign, and other things sometimes may be asked in acute pulmonary edema to differentiate it from ARDS. Suppose in acute pulmonary edema, usually cardiac shadow is enlarged, edema is more central. In ARDS, opacity usually more peripheral. Other things, ma'am, sometimes may be asked with hemosiderosis. How would you differentiate? How can you differentiate it from miliary tuberculosis? Maybe asked. So students should remember these things. Thank you very much. So, ma'am, we can proceed for the next speaker, Dr. Shamim Chaudhary. So he will be talking on cardiomegaly. Actually, cardiomegaly sometimes that includes enlargement of the heart as well as pericardial shadow, that is the cardiac chill out is enlarged. That is sometimes commonly termed cardiomegaly. I think he will cover the both things. Dr. Shamim.
Sir, am I visible?
Yes, visible and audible also.
Honorable panel of expert, respected moderator and faculties and learned audience, Assalamu alaikum. My topic of presentation will be the X-ray with the cardiomegaly. The normal etiologies for the X-ray cardiomegaly is the multiple valvular heart disease, pericardial effusion, cardiomyopathy, shunt anomaly, and absent anomaly. And in case of left ventricular hypertrophy, it is very often we see the heart shadow is enlarged, and it was commented as in cardiomegaly. Shunt anomaly is already described by the Professor Rahiduzzaman sir. So my topic will be the discussion will be the other causes of the cardiomegaly. Now, this is my first X-ray that is showing there is obvious cardiomegaly. Now, what we have to look for then the cardiac apex, whether it is LV type or RV type, it is the angle of the left cardiophrenic angle is obtuse, so it is an LV type apex. With there are other features like there is double heart border, with there is widening of the carina, and there is left atrial appendage enlargement. So probably this is a case of multiple valvular heart disease with probably the mitral stenosis with mitral regurgitation, as there is features of left atrial enlargement. My next X-ray is very similar to that one. That is also a case of mitral regurgitation with the features of left atrial enlargement with some features of pulmonary edema like venous congestion. My next X-ray, there is a cardiomegaly, but that not so much huge. But there is apex is the LV type with the obtuse angle, and there is right heart border is the left. There is a biatrial border, and there is also widening of the carina. So and the left atrial appendage is straightened. So the probable diagnosis will be the mitral stenosis with mitral regurgitation. Now my next X-ray, the X-ray in this X-ray that is shown that is the LB type apex cardiac shadow is mildly enlarged with angle of the left cardiophrenic angle is obtuse with some sorts of post-stenotic dilatation of the ascending aorta. So probably this is a case of aortic stenosis with LV hypertrophy. My next X-ray, there is obvious cardiomegaly with there is aneurysmal dilatation of the ascending aorta with unfolding of the aorta. So this is a case of aortic regurgitation. Probable causes could be Marfan syndrome or hypertension. And this is my next X-ray. There is obvious cardiomegaly with lung findings. There is oligemic lung field with no vascular markings, are less prominent, with angles of the heart are acute angle, both the right and left cardiophonic angles with the margins are clear margin. So probably this is a case of pericardial effusion. Now, what are the signs of the pericardial effusion? There will be some narrow vascular pedicle, rounded or globular appearance with no particular chamber identification, with cardiophonic angle become more and more acute and with oligemic vascular markings. Now, this is a similar type of X-ray that is shown previously. Like this, there is also cardiomegaly, but here there is LV type apex with angle is obtuse, left cardiophonic angle, but right cardiophonic angle is acute. Margins are quite bit sharp. Vascular markings are quite normal, but there are some forms of pulmonary venous condition. So this is probably a case of cardiomyopathy with chambers. We are identifying it. The cardiophonic angle of left cardiophonic angle is obtuse. There are some signs of pulmonary venous condition. Vascular pedicle is quite normal or sometimes may be dilated. Now, this is an X-ray of cardiomegaly that is showing there is an unfolding of the aorta, that is aortic knuckle is prominent. Probably this is a case of chronic hypertension. This is another X-ray where showing there is cardiomegaly, but the LV apex is not bulge laterally and not inferiorly bulging, and there are some forms of, and the vascular markings are quite normal, with some sorts of rim of calcification is noted in the area. So this is a case of chronic old myocardial infarction with LV epic aneurysm. Now, this is the last two X-rays that this type of X-rays students usually face in the exam, with the huge cardiomegaly with oligemic lung field with the vascular, no vascular markings, and borders are sharp. But look at the apex. The apex are not quietly acute or any, both the angles are obtuse. So with this type of X-ray, it is very hard to say a single diagnosis. Rather, it would be better to say multiple differential diagnoses. With this type of X-ray, the differential according to the features, the first differential will be pericardial effusion, and second differential would be Epstein anomaly, as there is appearance of this is not typical globular shape, but some sorts of box shaped heart. But in both cases, there are angles are the obtuse. These findings not goes with favor of any of these. But least possibilities of multiple valvular heart disease or cardiomyopathy, as there is vascular markings are there are no vascular markings, oligemic lung field. So there is least possibility for with these X-ray that there is multiple valvular heart disease or cardiomyopathy. Now, this is a similar X-ray with the oligemic lung field with the clear margin, with the cardiomegaly, with globular or box-shaped heart. Probability is the Epstein anomaly or pericardial effusion, least possibility for multiple valvular heart disease or cardiomyopathy. Now, how can we differentiate between pericardial effusion, Epstein anomaly, and dilated cardiomyopathy or valvular heart disease by X-ray? First, the heart shape. In pericardial effusion, it will be water bottle or globular shape. Quite similar with the Epstein anomaly, that is box shape or globular shape, but not a particular shape in case of dilated cardiomyopathy or valvular heart disease. Cardiophonic angles are usually acute in both pericardial effusion and Epstein anomaly. However, it will be obtuse or LB type in dilated cardiomyopathy or valvular heart disease. Pulmonary vasculature will be oligemic in pericardial effusion and Epstein anomaly, and it could be normal or pulmonary. There will be pulmonary venous congestion in case of dilated cardiomyopathy or multiple valvular heart disease. Chamber could not be identified in pericardial effusion, but there will be some identification in case of Epstein anomaly, as there is right atrium will be hugely dilated. And in case of dilated cardiomyopathy or multiple valvular heart disease, chambers can be easily identifiable with some sorts of dilatation of left atrium or right ventricular dilatation with or left ventricular dilatation. And thank you all for patient hearing.
Thank you, Dr. Shamim Chaudhary. Excellent elaboration. All the X-rays are excellent, and that is commonly put in the examination. Any comment from, first I will ask Professor Manjur Mahmood, then Rahiduzzaman sir for comment on Dr. Shamim's speech.
Thank you. Dr. Shamim has brilliantly presented all the X's that are related to cardiomegaly. So cardiomegaly is a very common X-ray in the examination. So I would like to tell some other possibilities that might come in the examination for the students actually, because Dr. Shamim has already said in details and how to differentiate between different type of cardiac enlargement. So other possibilities that might come in the exam are actually nowadays pacemaker X-rays are given, pacemaker ICD CRT. These X-rays are already are given because there are multiple leads. Okay, and then ventricular aneurysm has been shown by Dr. Shamim. This is as part of the myocardial infarction. Pericardial effusion already told. Prosthetic valve X-rays, Madam has already shown. There may be multiple prostheses in the exam, and to differentiate between aortic and mitral prosthesis, both may be present in the same X-ray. So this could be a possibility. A dextrocardia might come or as an isolated dextrocardia or a situs. These X-rays are also available for exam. So again, chamber enlargement becomes the most important X-ray that comes frequently in the examination. So I have told some other possibilities. Thank you very much.
So thank you, Dr. Manjur Mahmood.
Actually,
yes,
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 just a small comment. Actually, we started with this. This is our first X-ray session, and we plan to have. And as you have, yes, and as you, all the things that you have pointed, we are actually planning to have other X-ray sessions. So hopefully you can join us for those as well. So our next session is actually going to be of pulmonary stenosis, coarctation, dextrocardia, and our last is on devices, because there are so many devices nowadays that the student needs. But thank you for highlighting this. It is very important that these need to be covered. Yes, thank you.
Yeah, because somebody will be taking the exam in January. So yeah.
Thank you, ma'am. Thank you, Manjur bhai. Professor Rahiduzzaman sir.
Thank you.
And regarding cardiac, yes, sir.
Dr. Shamim almost covered almost all the aspects of cardiomegaly. Only one thing I want to say to the teachers actually, you should present like how a student should approach a X-ray with cardiomegaly. What is the step-by-step approach to a patient with X-ray? When a X-ray with cardiomegaly is shown to a student, how he or she will approach? Whether she will start with the angles, whether he should first see the pulmonary arteries, pruning. And so it should be like this. Not when there is an X-ray of cardiomegaly, what the student should first look for. Then step by step, he or she can approach the diagnosis. Definitely.
Sir, with auspice examination, the system a bit changed. Not like that we faces.
he or she need not to describe it. আমি বলছি ডিসক্রাইব করার দরকার নেই, বাট ফর ডায়াগনোসিস
Findings, important findings you have to tell.
কোন ফাইন্ডিং এর কোন ফাইন্ডিংটা দেখবে, তাহলে তার জন্য ইজি হবে।
Exactly.
করার দরকার নাই, কিন্তু সে যখন একটা এক্সরে দেখলো হার্ট এনলার্জ, হাউ হি অর শি উইল স্টার্ট এভালুয়েটিং দ্য এক্সরে, কোনটা আগে দেখবে কোনটা পরে দেখবে তারপর সে একটা ডায়াগনোসিস আসবে, হ্যাঁ এখন মনে হচ্ছে এটা ডায়াগনোসিস। এটা ডিসক্রাইব করার দরকার নেই, এটা তার মাইন্ডের মধ্যে সাবকনশিয়াস মাইন্ডে সেটা চিন্তা করবে, এটাই বলছি আর কি। সো আই থিঙ্ক it is one of the most difficult X-ray, cardiomegaly, are definitely the teachers never expect the diagnosis. They expect the differential diagnosis. Nobody expect that he or she will just go for the exact diagnosis. Even if somebody says the exact diagnosis, somebody becomes a bit suspicious whether he or she knows the answer.
No X-ray.
Know the diagnosis, don't utter it. Always go for a differential diagnosis. So actually, it was a wonderful session and by all the speakers. I think they have all explained very beautifully their part of the lecture, and thank you very much. I think all the students also benefited very much from this. Thank you.
Thank you, sir. Thank you very much. Any comment from faculty, Dr. Tufik Shahriar Haq, Dr. Mir Nasaruddin, Professor Amal Choudhury? Comment, please. Any comment? Dr. Tawfiq, Dr. Nasrud, Dr. Mir Nasaruddin?
Thank you, Dr. Ashok, for presenting a wonderful session covering the X-ray introduction and some special X-ray, especially the Madam lectures have been amazing, very amazing. I have learned a lot of things from her lectures regarding mitral stenosis.
Mughal. That is very interesting.
And then Shamim have seen several X-rays, and Professor Munjur Mohammed already said you have to see so many other X-rays, especially IC devices, CRTs, etc. And another cardiomegaly cause is the congenital complete heart block. Sorry, that is complete heart block. Chronic complete heart block is one of the important causes. Thank you, Shamim, for your.
So other thing is important, cardiomegaly and enlarged cardiac shadows. Sometimes you may be asked, what is difference between cardiomegaly and enlarged cardiac shadow? Suppose there is huge pericardial effusion. Heart is small. Heart is not megaly, that is heart is small, but the cardiac shadow or cardiac silhouette is enlarged. That is one thing. Another is multiple, like Dr. Shamim was telling, MS with mitral regurgitation. So this is actually the mixed valvular disease. When two valve is involved, mitral stenosis with aortic valve involvement, that is called multivalvular disease. And with single valve stenosis regurgitation, that usually should be regarded as mixed valvular disease like this. And other thing, sometimes maybe asked oligemic lung field and pruning. These two things may be asked, Dr. Professor Munjur, maybe. How would you differentiate pruning or oligemic? Maybe asked. I think as an examiner perspective, I'm for the student, they should know it. So
the term pruning means that the prominent pulmonary arteries are restricted to the central part. I mean,
central part, exactly.
Middle 1/3 of the pulmonary vasculature. And suddenly there is a cutoff, and then the peripheral vessels are not seen.
Exactly.
So this is pruning. Oligemic lung field means that all over the lungs, the vascularities are not prominent actually.
Like that in.
I mean, it's a global phenomena. Oligemic. Such as pulmonary
little blood is going to the pulmonary circulation.
And we can also tell there is pruning, that is peripheral attenuation of the vessels, attenuation of the peripheral vessels.
Right. Exactly.
Yeah. And actually, pruning ke oje centralization bole, American radiologist আর কি, centralization of the
centralization.
যেমন এটাকে বলে cephalization, যেমন বলে upper left venous diversion, এটাকে বলে centralization. মানে ওই heart.
And another interesting is that pruning is a gardener's term. Gardening jara kore, but it is a gardener that pruning. So you imagine a huge hedge, একটা hedge, and gardener বড় scissors নিয়ে গিয়ে he just prune করে ফেলো, অনেক শাখা প্রশাখা ছিল, গাছটাকে কেটে সুন্দর একটা শেপে নিয়ে আসলো, ওইটাকেই বলা হয় প্রুনিং।
Pruning,
So pruning is a term, is an English term which is used by gardeners. So when the gardeners use a very large shear and they remove the excess leaves and make the bush in a shape, certain shape, that is called pruning.
Very interesting.
Dr. Dhiman,
Thank you, ma'am.
একটা কোশ্চেন ছিল ধীমানের কাছে।
জি
ধীমান,
স্যার।
যেহেতু বেসিক বলছে এক্সরে সম্বন্ধে, সেজন্য প্রশ্নটা আছে যে সামটাইমস the X-rays are overexposed or underexposed. The overexposed, underexposed X-ray can mislead the diagnosis.
Yes.
Underexposed হলে pruning মনে হবে, overexposed হলে upper lobe diversion মনে হবে। So how is this possible to differentiate between how can we diagnose this X-ray is overexposed, underexposed?
এখানে আরেকটা পয়েন্ট স্যার, অনেক সময় শোয়া এক্সরে করে, দাঁড়ায় এক্সরে করে, এটাও আরেকটা।
ওটা তো অন্য জিনিস, কিন্তু এমনি কি সম্ভব বোঝা যে এটা ওভার এক্সপোজ বা আন্ডার এক্সপোজ? কারণ ওভার এক্সপোজ হলেও ডায়াগনোসিস ভুল হয়, আন্ডার এক্সপোজ হলেও মনে হয় প্রুনিং হয়ে আছে। So is possible to understand?
Sir, normal exposure, if there is normal exposure, then the vertebral bodies will be seen in the lower part of the chest X-ray, in the inside the heart, in the lower part. Then it is the normal exposure. The exposure is normal.
So if the vertebral body becomes obvious, then either it is AP view or it is overexposed. Yeah.
Yes.
Yes. And other thing, X-ray with mitral stenosis and secondary ASD, Lutembecker.
Very interesting thing.
Yeah.
How to differentiate if the patient already has ASD with MS. Patient MS has been already described very beautifully by Professor Fazila Malik. So a patient comes with MS and also have a shunt anomaly, ASD. So Dr. Shamim, is there any point in favor of adding ASD to MS, mitral stenosis?
Sir, with the Lutembecker syndrome, there will be left to right shunt by the ASD. So left atrial pressure will not rise so much. So left atrial enlargement will not be so much evident in the X-ray. That is a clue for
Exactly.
that can be.
And rather on the right side, there obvious pulmonary artery.
Pulmonary artery can be
dilated. Pulmonary will be dilated. Hugely
Exactly.
dilated.
Yeah.
So shunt will be more. If we compare with the even small ASD, there will be more shunting from left to right. So right heart volume overload would be there, inappropriate to the size of the shunt. So pulmonary artery will be more enlarged, RV will be enlarged, right atrium will be enlarged, but left atrium will not be enlarged so much.
So we'll be seeing more features of the shunt. So
Shunt,
basically, from the X-ray, we will not be able to diagnose Lutembeckers. For examination purpose, we will say this is a X-ray of a shunt anomaly, probably ASD, right? Only if they give us clues as well. Like in MRC PINA, they give you clues also. Patient has this rumbling, this, and so then maybe you can say Lutembeckers. But just X-ray, I don't think you can say, right?
And this is so rare combination, better to not comment or put the differential diagnosis in the radiological.
Right. Yes. Just go for the shunt. Go for whatever is obvious.
Yes. So thank you, our panel of experts. Thank you all the faculties. We can end now, sir, madam.
Yes, of course.
We can end it.
Thank you.
So thank you all the attendees.
দুটো প্রশ্ন ছিল আমাদের ইসেদের, এই প্রশ্নের উত্তরটা একটা প্রশ্ন করছে যে
So I was searching for no question is there.
Comment giant LA. X-ray থেকে
Giant LA. What does you mean by giant LA? Dr. Shamim, Cardiomegaly.
বলা যাবে? Giant LA বলা যাবে?
Giant LA is
Echocardiographically, sometimes we call it giant LA.
giant LA.
Okay, no, but radiologically, you can also call it a giant LA, okay?
Madam,
So
what 7 centimeters?
Yes, it is like giant LA, it is like a football heart bole. Eta when this American use করে the American এরকম football খেলে না,
Rugby.
rugby,
Baseball,
junior football, rugby, that junior football
rugby.
size, if it is more than 24 centimeters or something like that, the 20 some dimensions আছে, which is more or equal to a junior football, then it is a giant LA.
আমেরিকানরা ম্যাডাম, আমেরিকানরা যদি ইকোকার্ডিওগ্রাফি
America
70 এর উপরে পায় ডায়ামিটার, তখন এটা বলে জায়ান্ট এলএ।
ইকো না, কিন্তু এক্সরে কথা বলা হচ্ছে। এক্সরেতে জায়ান্ট এলে বোঝা যাবে তাহলে ওই বেসবল দেখে, মানে
রাগবি ফুটবলের
rugby.
তাহলে কি ম্যাডাম আপনি যে একটা পিকচার দেখালেন যে obliquely from the left bronchus up to the right border of the
7
heart,
centimeters,
right?
more than 7 centimeters.
So 7 centimeter means 70 millimeter echocardiographically.
Maybe we'll have to look it up, but with this ফুটবলের সাথে কম্পেয়ার করে জায়ান্ট ফুটবল, মানে ফুটবল হার্টও বলে তখন ওইটাকে, যখন জায়ান্ট এলে হয় ওটাকে ফুটবল হার্টও বলে।
Thank you, ma'am. Thank you, Manjur bhai. Thank you, all the faculties. Thank you, all the attendees. We can end this program for today, and we'll just in the next session. We are inviting everybody to attend in our next session, National Heart Foundation cardiac course for postgraduate student.
থ্যাংক ইউ।
Thank you.
Thank you and good night.
Thank you.
Thank you. Assalamu alaikum.
Thank you.